we created an initial description of what we wanted to do. There was a team that went on site in May, talked to all the players, visited hospitals, visited pharmacies, and collected data. And the data was at the level of medicine and its availability, the specific diseases and how they were treated, how much people were paying to get access to hospitals, etc. The one number which we want to change is the in-stock level of medicines. Because if medicines are available in stock and people get treated on time, outcomes are very different from between. So that number, I mean, if you think about those numbers, that number is very low, far less than acceptable. We'd like to change that. The willingness to pay is not very high, which means a lot of the medicine and a lot of the resources are being provided by donors. For some countries, as much as 80 to 90% of their healthcare needs come from donor funding. Now, when such things happen, any efficiency in terms of delivery of the medicine really translates into more people having access. So, in some sense, that's the utility. For many of us as faculty, sitting in our offices, if we can bring our resources to bear, I can't get on a plane, go over there and change anything. But to the extent that we can provide services which would otherwise be expensive for governments or not-for-profit organizations, we're willing to volunteer. This translates into descriptions of motivations for problems that really motivate students. It's clear to me that my kids would be less interested in supply chain management, but the moment I talk about its impact on poorer sections of the world, where in some sense I feel a responsibility, just as our students do, it's a lot easier conversation. And my personal feeling is that our students do care. A lot of faculty care, the public care, and we're a public institution which, in the process of education, educate people to play a role in the world. That's my motivation.